Hello everyone and thanks for tuning in. This is a quick 15-minute talk on ST elevation, myocardial infarction, and RCICU from a resident perspective. Obviously this topic is very expansive and we'll be doing a cursory overview of several different aspects of the patient who is presenting with an acute STEMI to our J31 ICU and the practice patterns that are seen here at our ICU at Cleveland Clinic. The majority of this information was taken from the 2013 ACCF AHA guidelines for the management of STEMI with the link in the notes section. Reminder, this is not for any sort of medical advice. This is more used as an educational tool and as a guide specifically for Cleveland Clinic residents as they enter our ICU. Our three main objectives for this talk are as follows. One is to review the definition of ST elevation myocardial infarction by the 2013 guidelines. Next is to review the medications, and we have identified 5 per the guidelines that must be strongly considered in every patient who presents with ST elevation myocardial infarction and had appropriate reperfusion with percutaneous coronary intervention or PCI. The last objective is to review and familiarize yourself with the major complication categories in the post-STEMI patient who receives reperfusion and how to quickly evaluate for these often catastrophic manifestations. So this is the overview we will use and the outline for the talk. First, we will go over several ECG examples that show ST elevation MI in different patterns. So our first example ECG is showing a typical infarction pattern that might be seen in the J31 ICU, which is accepted by the fellow. Just to remind you, these ECGs are faxed from standalone EDs or outside hospitals that are then evaluated by the fellow overnight or during the day and then accepted for cath lab activation. This ECG, I encourage you to pause the PowerPoint right now and take your own interpretation. But this ECG shows sinus rhythm with a borderline tachycardia, and most striking is this anterior ST elevation in leads V1 to V5, along with the high lateral leads in 1 and AVL. There's an arrow that is showing a small reciprocal ST depression in lead 3. Furthermore, in lead V3, there's a thin curved arrow that is pointing at the TP segment. I wanted to highlight this because this is the reference segment that you should make any sort of ST segment elevation diagnosis from. Here's another ECG. This shows an inferior myocardial infarction. I've starred the areas where there's ST elevation, which are in the inferior leads 2, 3, and AVF, and there's an arrow showing the reciprocal ST depression in one of the high lateral leads, AVL. Remember, we are always comparing to the TP segment. Shown here is another inferior MI. The stars indicate where the ST elevation are, and that's in 2 and AVF, along with the lateral leads or the apical leads, V5 and V6. You'll see arrows pointed at V2 and V3, and this is a sign of ST depressions, which represent posterior wall involvement. So the characteristics of this are a tall R wave, and so the arrows in V3 point to this tall R wave, and then the ST depressions that are horizontal in V2, V3, which if you flip the ECG around, this is just an ST elevation, but in the posterior wall of the myocardium. So now we will discuss the definition of an ST elevation myocardial infarction per the 2013 guidelines. So now that we've seen some examples of the ST elevation MI by ECG, the clinical definition put forth by the 2013 guidelines will be reviewed. So here they describe STEMI as a clinical syndrome defined by characteristic symptoms of myocardial ischemia in association with persistent electrocardiographic ST elevation and subsequent release of biomarkers of myocardial necrosis. So this is particularly referring to troponin. So here they highlight history, ECG, and biomarkers. 2 key things that often skew the interpretation in the ECG is left ventricular hypertrophy or left bundle branch block. Now there is a specific millimeter cutoff in the setting of ST elevations, and one easy way to remember it is that it's 1 millimeter in at least 2 contiguous chest leads or the limb leads for both genders in all the leads. Now there's specific rules for V2 and V3 where instead of 1 millimeter it's 2 millimeters for men and 1.5 millimeters for women. Otherwise, as noted in the past example, ST depression in the anterior precordium, so V1 to V4, with a tall R wave may indicate transmural posterior injury. Now in J31, you may see STEMIs that come in different times, meaning somebody has chest pain right away and comes in, or someone has had on and off chest pain for several hours and comes in. And there's a concept called the evolution of the ST elevations on an ECG. This graphic is from a paper by Nabel et al. The ECG characteristics of myocardial infarction actually start with hyperacute T waves that resemble hyperkalemia, and this then progresses to ST elevations, and then Q waves with ST segment elevation and actually inverted T waves. While you're in 31, you'll be able to see all sorts of different ECG patterns, and you may see hyperacute T waves, but you should not get fooled if there's no ST elevation, because this may just be early myocardial infarction. So to help better understand the coronary anatomy, this figure on the left shows the vascular patterns of the coronary arteries and electrographically where they line up. Keep in mind this is not always correct. So for example, the RCA is listed as 2-3 AVF, but you may have a patient with ST elevation in 2-3 AVF that has a circumflex artery. The right figure is a diagram showing these leads in an almost 3D structure and how the arteries will reflect the lead involvement. Noted here is I brought up that a posterior ECG, so including V7, V8, V9 as the leads wrap around the back, can help identify a posterior wall myocardial infarction, as well as the leads V3R, V4R, V5R, and V6R can help identify if the right ventricle is being involved in the infarction. Along with our previous definition, here are some examples of STEMI equivalents in the ECG morphologies that also represent epicardial ischemia and warrant strong evaluation for cath lab activation. So next we're going to discuss reperfusion therapy. So in J31, you'll often hear about PCI, or percutaneous coronary intervention, for your reperfusion strategy. This is not an easy decision. There's a whole algorithmic sort of understanding of who goes for PCI. Rarely, some patients may not be candidates for reperfusion therapy based on timing from first medical contact to when they can actually get to the cath lab. This is a STEMI reperfusion algorithm that will at least try to highlight why the J31 fellow always stresses on the phone how long until the patient can get to the cath lab. If that number is greater than 120 minutes or 2 hours from the first medical contact, strong consideration should be given for lytic therapy and then transferring the patient. You may not see this at all in your time, but it helps to have a basic understanding of what everyone is thinking when they take a call from the transfer center for a patient who is having a STEMI at an outside hospital. The following two sections are when the patient comes back from the cath lab, the medications, and the complications that you as the resident should be particularly aware of. So first, there are a lot of things to consider as far as therapies to be given, oxygen, pain relief, etc. But the main things really surround the medications that each patient with STEMI should be on. So per the guidelines, there are 5 major classes of drugs that need to be strongly considered, and you at least have to have a reason for not doing it or ordering the medication. So beta blockers, ACE inhibitors, ARBs, aldosterone antagonists, aspirin, a second antiplatelet agent, and statins should all be strongly evaluated in each patient. First, beta blockers. These should be initiated in the first 24 hours in patients who do not have heart failure, low output, or significant bradycardia. The specifics are listed here, but numerous trials have shown that the beta blocker therapy is helpful even in those with a reduced ejection fraction. Ideally, the patient comes back from the cath lab and an echo probe is immediately placed on his chest or her chest to evaluate the cardiac function, along with a careful assessment of hemodynamics to make sure the patient isn't hypotensive, or overtly tachycardic, or bradycardic. If the patient is not in heart failure and has stable blood pressure, it is reasonable to start beta blockers early, right after the patient returns. Bradycardia, particularly after an RCA infarction, may be a reason to hold off on beta blocker therapy until it resolves. Furthermore, if your patient comes back quite tachycardic, it is useful to evaluate why the patient is tachycardic, as this could be the first sign of a brewing shock picture. The guidelines specifically refer to a high-risk population group, patients greater than 70 blood pressure less than 120 systolic, sinus tachycardia greater than 100, or sinus bradycardia less than 60, and a delayed presentation of their MI as those who may not be candidates for beta blocker and should be closely monitored for shock. The next medication is ACE inhibition or ARB therapy. These should be administered within the first 24 hours to all patients with anterior ST elevation MI, heart failure, or an ejection fraction less than or equal to 40%. Now, if you have a patient without these things, say an inferior ST elevation MI with preserved ejection fraction, there's not the same urgency to start a ACE inhibitor in the first 24 hours. Lastly, aldosterone antagonists, specifically eplerenone or spironolactone, should be used in patients with ST elevation MI with an EF less than or equal to 40% and either symptomatic heart failure or diabetes. The caveat here is you probably won't be ordering this in the unit in the immediate day after the catheterization because part of this says that they have to be on optimal medical therapy, meaning those patients should be on beta blockers and angiotensin receptor blockers or ACE inhibitors, and usually in the trial this took about 3 days to get them on optimal medical therapy before they were started on aldosterone antagonists. It is important though to write this in the note that the patient will be a candidate for this so that when the patient goes to the floor he can make sure that he or she gets the ideal medical therapy. Now the most important medical therapy is more than likely the antiplatelet therapy because this is what tries to keep open the stent that was just placed. So, first, aspirin is usually given in a loading dose in the emergency department at first medical contact, so you probably won't write for this. The loading dose is usually a full dose aspirin. In the guidelines, it can either be half or full, but convention here is for giving aspirin 325 milligrams. You will be in charge of writing the aspirin 81 milligrams order for every day indefinitely to this patient. Next, a second antiplatelet agent is used, and once again, this is usually given as a loading dose, and I've listed the three options, clopidogrel, prasugrel, and the preferred option, ticagrelor. These are already usually given in the loading dose. Your job is to make sure that the standing dose is ordered. So in the case of ticagrelor, 90 milligrams twice a day should be ordered by the time the patient is back from the cath lab. There are certain small considerations to be made, such as the bleeding risk is higher with ticagrelor than clopidogrel, but it seems as if ticagrelor is more effective than clopidogrel, and in patients with stroke, prasugrel is not an option. This is a discussion to be had with the fellow to make sure that the appropriate second antiplatelet agent is made. Lastly, statin therapy should be ordered for all STEMI patients. This is level of evidence B, but there's a clear guideline that says that high-intensity statins specifically should be used. By convention, the most commonly used is atorvastatin 80 milligrams here, and that should be put on the med list regardless. The last section of the talk is on the complications. Many of these that are listed are extremely grave, but early identification can save lives. The incidence goes up as the time from symptoms is prolonged, meaning if there is a delayed presentation, these are more frequent. I've listed 6 classes, but there are others that are frequent as well. So the first is cardiogenic shock or pump failure. This is a feared complication after STEMI. Due to the ischemic injury on the heart, the patient now has heart failure and an inadequate blood pressure to perfuse the body. You can think of this as either being caused by just a large infarction that usually involves the left ventricle, or that the patient has mechanical complications such as mitral regurgitation, which we will go into in the subsequent slides. You'll see cardiogenic shock in a bimodal distribution. It's either in the first 24 hours or the patient comes back from the cath lab unstable, or several days later. In any case, in that patient who comes back unstable, a dedicated evaluation needs to be done to optimize the heart function. Either a decision needs to be made for an assist device, either an intra-aortic balloon pump, which is shown in the tile on the left, or an Impella device, which is on the right, while simultaneous evaluation of why the patient is in shock, using bedside echocardiography and, if necessary, a pulmonary arterial catheter or Swan-Ganz catheter for invasive hemodynamic monitoring to help tease out the shock etiology and choose the appropriate treatment strategy. Those patients who are on the borderline, such as being hypotensive, tachycardic, or in overt cardiogenic shock, should not receive beta blocker therapy until their hemodynamics are defined. RV infarction is seen in approximately 1/3 of patients with inferior STEMI. There are sometimes characteristic patterns on ECG, such as ST elevation in the inferior leads, along with in V1, that are more suggestive of RV involvement. The clinical triad of hypotension, clear lungs, and elevated jugular venous distension may suggest this. In everyone with an inferior STEMI, a quick bedside echocardiogram should be used to evaluate the RV function and to rule out RV involvement. A right-sided ECG can be helpful prior to heart catheterization. If hemodynamics worsen in a patient who has suspected RV involvement, maintenance of RV preload is the key, and avoidance of those drugs that can reduce preload, such as nitrates and diuretics. The RV can be seen in this apical 5-chamber view on your screen, on the right side of your screen, and is nearly the size of the LV. So now, mechanical complications, or some of the most feared complications of STEMI. There are several clues on the presentation. In a patient who comes back from the cath lab in heart failure, consideration should be made for some of these pathologies listed. A murmur on exam may represent a ventricular septal rupture or mitral regurgitation. The bedside echocardiogram is a necessity, using color flow imaging to demonstrate blood flow. Surgical consultation is of utmost importance if these are diagnosed. So first, mitral regurgitation is either due to a papillary muscle rupture, usually from a circumflex infarction, or from the LV being so remodeled and causing MR from stretch. The patient will have sudden pulmonary edema and may not have a murmur right away. If the bedside echocardiogram confirms MR, urgent surgical consultation is necessary, and temporization with an intra-aortic balloon pump should be considered. Ventricular septal rupture also presents with profound shock and a loud systolic murmur. This is more frequently seen in patients who receive lytics. The definitive treatment is emergency open heart surgery, even in those patients who are hemodynamically stable, because a small rupture can expand abruptly. LV free wall rupture is characterized by progressive chest pain after the heart catheterization and progression to hemodynamic collapse. It has been observed more commonly in anterior MI and needs to be sorted out from either stent thrombosis or pericarditis. The last complication, ventricular aneurysm, is usually seen several days after ST elevation MI, or can be seen in delayed presentation in patients who have persistent ST elevation and chest pain after heart catheterization. Electrical complications are common and do not usually require intervention. We can break these down into ventricular arrhythmias, including ventricular tachycardia and ventricular fibrillation, supraventricular arrhythmias, including AFib, and bradyarrhythmias. Now, with the use of primary PCI and in a timely fashion, there's much less VT and VF. The importance is that we monitor the telemetry of these patients and review the 12-lead ECG so that we can find these complications early. Treatment includes optimizing electrolytes, the acid-base status, and treatment of any underlying shock. Beta blockers are really key here because they've been shown to reduce the incidence of VF and VT in the immediate post-reperfusion period. Pericarditis should be considered as well for recurrent chest pain after STEMI that has the characteristic pattern such as positional chest pain, pleuritic, radiating to the back or trapezius, and associated with a rub. Chest pain after PCI, though, needs to be separated from in-stent thrombosis, which is obviously much more fatal, and LV free wall rupture, which was touched on previously. The last thing to consider, and one of the most important, is to have an understanding of how the catheterization was done, meaning the access site. So there's two types, either radial or femoral. In the radial access site, the main things to worry about are radial artery dissection or injury, which can show up as either a pulseless hand or a radial artery hematoma. A quick evaluation of the risk can figure out if there's any sort of complication there. Femoral artery access has about 6 main complications, but hematoma, pseudoaneurysm, and AV fistula present as a pulsatile mass that may or may not have a bruit when auscultated with a stethoscope, and Doppler ultrasound is used to investigate this. RP bleed is the main one I want to touch on today, because if there is hypotension and it appears to be hemorrhagic shock, then you have to consider RP bleed from the femoral access site, and CT non-contrast of the abdomen pelvis is used to diagnose this. So we covered a lot during this 15-minute discussion. We reviewed the STEMI definition by 2013 guidelines, which I've listed here. We reviewed the 5 medications to strongly consider for post-STEMI care and to either evaluate why or why not you're not using it. And we lastly reviewed the major complication categories in the post-STEMI patient that we would see in J31. A lot of this has room for a resident evaluation of the patient, and it can really help facilitate care as residents are involved in the care of these patients post-reperfusion. Most of the information in this PowerPoint was from this Consensus 2013 Guideline Management of ST elevation myocardial infarction. This document is associated with all the major trials that formulate the recommendations along with the strength of evidence, and I recommend taking a look at this when you have time so that you can understand the basis of why we make certain decisions on patients with STEMI in our unit.